you to the July edition of the ALIBSA webinar. So if you haven't been to an ALIBSA webinar before, if you don't know what ALIBSA is, so ALIBSA is Aging, Lifestyle, and Vaccination. So we were established in February 2023, so over 3.5 years. The idea behind ALIBSA is to exchange the knowledge that a lot of doctors and academics would have about the lifestyle our global majority communities have, the Black and Asian communities have, and then support our journey to better health, especially focusing on that aging journey. So as part of that, we do monthly webinars, so that features GPs, public health specialists, service providers, etc., who discuss these things, especially healthy aging and the well-being of the older adults in our community. As we are all aging, this is for everyone. So our mission is to advance health equity by providing health information resources, such as through this ALIBSA webinar, improving health literacy, and improving community-based participatory research. So often the research itself would be dominated by different groups, and sometimes the ethnic minority groups are not well represented in research. That means our knowledge and our issues and conditions might sometimes be not studied enough for us to have better health. So ALIBSA strives to change that as well. Across the world, we have over 250 members, as you can see, spread across the world. So we have got a very thriving WhatsApp community. So we use that space to talk about these things. You can also get blogs about the previous webinars, recordings of previous webinars, etc. So if you want to be part of that ALIBSA community, please join us on the WhatsApp group. The link to the group is given below. It will also be put in the chat box. You can also message either of those two numbers, and then we will be very, very happy for you to be part of the ALIBSA community. We also have our webinar website, our ALIBSA website. It's called alibsa.com. So there you can read about the previous blogs, contact us, and then learn a bit more about ALIBSA. We also have a YouTube channel, so that's where you can see the previous webinars. As you can imagine, over the last 3.5 years, we have had some very, very important and interesting presentations and webinars. So if you want to go through them all and take learnings from them all, they are all available on our ALIBSA YouTube channel. You can just Google it and you would find it. So with that, I am really, really happy to welcome you again to the ALIBSA webinar. My name is Alosh. I am the webinar lead for ALIBSA. I am also a founder and CEO of an organization called Cricket Cube. We focus on supporting people to be active and socially engaged. And with me, I've got Shakiro.
Hi, everyone. Good evening. Thanks for joining the webinar today. My name is Shakiro, and I'm a pharmacist with an interest in public health and research. So I'll be taking you through the admins or the admin member of ALIBSA. First with our Chief Executive Officer, Dr. Ade Odumosu, our founder, Professor Fatia Ni Odumosu, the webinar lead, Alosh, Mr. Oluwatobi Fatola, the Media and Communication Lead, Dr. Abolale Adesokbe, our Operations and Events Lead, and Dr. Zengma, the Outputs Lead. We also have Marcia May, Grants Coordinator, and myself as the Secretary. So we have our wonderful volunteers, including Aisha, Rodia, Dr. Hadi, Aziza, Zuleikha, Shivani, Ayola. They have been so wonderful. Thank you all. So our agenda for today, introduction to the webinar, and we have introduction to our guest speaker. I know we are ready to have the session. So the webinar discussion would be based on colon cancer awareness and what you need to know. Then we have our comments and question and answer session, as well as the feedback. Then we have the closing remarks. So for us to have a seamless webinar and for everyone to enjoy today's session, please be on mute. You can switch on your camera too. Would like to see your beautiful faces, and please don't feel free to ask questions, and you can also drop your questions and comments in the chat box. Thank you. Okay, so I would read through a short biography of our speaker, Dr. Olayinka Adewumi, who is a consultant and is a consultant general surgeon with expertise in general surgery, gastrointestinal surgery, and hepatobiliary surgery. He currently serves at Aminu Kano Teaching Hospital, where he combines clinical practice with medical education and research. His professional interests include laparoscopic surgery and liver transplantation, and he is committed to improving surgical outcomes through training and evidence-based practice. Welcome, sir.
Thank you.
I'll just stop sharing my screen and then we'll go straight into the webinar. Yeah, welcome, Dr. Olayinka, and thank you so much for doing this. Are you able to see my screen?
Okay, good. Yes, I can see your screen now. Okay, can I go ahead? Can I start?
Yes, over to you.
Okay, thank you very much. And thanks to ALIBSA for giving me the opportunity to share my knowledge and expertise to the wider audience, in particular the communities of Blacks and Asians in the UK. Thank you very much. So, as has been earlier introduced, I'm Dr. Olayinka Adewumi. I'm a general surgeon, focused with gastrointestinal surgeon and hepatobiliary surgery. So, next slide. So, it is my expectation that at the end of this webinar, our audience should be able to know what colon cancer is and what are the risk factors and what are the warning signs of colon cancer, what are the screening modalities and the various treatment options and prevention. Then we'll try to trash out some myths about colon cancer. Next slides. So I don't know whether our audience, does anybody know what the colon looks like or what the colon cancer looks like among the audience? Or whether any of us has had screening on colon cancer, because this is very important.
You can use the chat box as well instead of Mentimeter because we thought that would be easier. So please use the chat box or raise your hands as well.
Okay.
I feel like colon is like a tube. That's what I'm picturing.
Okay. I can see your response, Alosh. Okay, fine. I'm sure that by the end of this presentation, we'll have a deeper knowledge about what the colon cancer is and how the colon looks like. So, next slide. So this slide is basically showing what the colon looks like. You can see the image on my right-hand side. So the colon is basically the large intestine. The intestine has the small intestine and the large intestine. So when we say colon, we are basically talking about the large intestine. And the basic function of the colon is to absorb water and prepare the undigested food for exit through the anus. For generally, the colon is about 1.5 meter long. And of course, as I said, it continues into the rectum and the anus and the anal canal. Next slide. So essentially, this is just replicating the previous picture. So these are part of the colon. The first part is the cecum, which is the dilated part, then the ascending colon, then the transverse colon, descending sigmoid, the rectum, and the anal canal and the anus. Next slide. So what is colon cancer? Now, colon cancer simply means there's an abnormal growth within the colon. Normally, the cells within the colon, they undergo wear and tear and they grow normally. That means when they're old, they die and new cells come in. That is what they call normal growth. But sometimes this growth may become abnormal, meaning that even where there are normal cells, you see the cells growing beyond what is expected. And that is when we say probably a process of cancer has taken place. Fortunately for the colon, most growth in the colon starts as what we call polyps. I will show us the image of polyp as we move on. And the growth, these polyps are initially harmless, but if they are unattended to, subsequently they may become harmful and eventually develop into full-blown cancer. So for those who are privileged to be screened early at the phase of colon polyp, we may be lucky to not to progress to full-blown cancer. Next slide. So to our audience, do we have an idea of how many cases of colon cancer do we have per year? I don't know any response on the chat box. 2 million. Sometimes it could be as high as that. Next slide. So essentially, globally, about 1.5 million patients develop colon cancer yearly. And it's very important to state that the colon cancer is the third most common cancer worldwide, following lung cancer and I think the breast cancer. So then followed by the colon cancer. And unfortunately, is the second leading cause of cancer death. Maybe because of poor screening, poor prevention skills and all that, which we'll also discuss. And about 1 million patients died yearly. And unfortunately, again, the deaths usually are more common among Blacks and Asians. And I think this is one of the reasons for this awareness. So among the Black community, what is the prevalence of colon cancer? Number one, the Black patients, people have the higher incidence of colon cancer. And one of the reasons that has been attributed to this problem is because of delayed diagnosis, low screening uptake in our community, and of course, disparity to access or disparity in access to healthcare. Some people have access to healthcare, some don't have access to healthcare. Some go for screening, some don't go for screening. So, and unfortunately, the Blacks and even the Asians have the tendency to present with even advanced stage cancer because of these reasons given. Other very important thing is that by the time the Blacks migrate from maybe Africa and Asia to the Western community, there's also changes in their diets, from fiber-containing diets to more refined foods, more westernized diets. So these are other factors that also precipitate the Black people to increasing risk of colon cancer. Next slide. Similarly to the Asians, traditionally the Asians have a low incidence of colon cancer, and the reason is because if you look at the traditional Asian people, they deal more with the eat a lot of fibers in the community. They eat more of traditional, made food. But over the last 2 decades, the Asians have gradually transformed their behaviors and lifestyle into a westernized model, and because of that, there's an increasing, prevalence of colon cancer among the Asians. And unfortunately, the Asians and Africans do not have access to, enough screening and healthcare compared to the white. So while there's an increasing incidence, there is no proportional increase in healthcare access, screening modalities and all that. So it's very important that this is one of the challenges why the prevalence is increasing among the Asians. Next slide. So why does this discussion matters to us? Now, it is very important to state that the incidence or prevalence of colon cancer is changing fast, particularly among the Asians and the Blacks. And the reasons have been explained earlier, changes in our diet, very important. Another very important thing that needs to be mentioned is that increasing trend or in the age of discovery of the cancer. Initially, colon cancer usually affects patients with 50, 60, 70 years. But can I tell you now that over the last 1 or 2 decades, the incidence or the prevalence of cancers among the young is gradually increasing. Another very important thing, again, that why this discussion matters to us is because a lot of people don't know the warning signs. And that's one of the reasons why we are having this discussion. Again, stigmatization, fear of interaction, discussing gastrointestinal symptoms. These are another reasons why a lot of patients, we have challenges with diagnosis. Then, of course, late diagnosis and treatment options. And these are the reasons why we're having this discussion. Next slide. So, what are the risk factors for colon cancer? We have divided them into 2. The factors which we do not have control over, which factors that cannot be changed, and those that we have control over. Now, number 1 is our age. We do not have control over our age. If we are lucky to grow old, then there is the risk is a risk factor. The older you are, the higher your risk of developing colon cancer. Number 2 is the family history. If you have a first or second degree relative with a colon cancer, maybe our brothers or sisters with a colon cancer, then we stand a chance of developing colon cancer. So the risk is higher in the first degree relative compared to the second degree relative. Then other factors include the inherited genetic conditions. Some patients have a genetic mutation, and these mutations are passed on from one generation to the other. So if any of us is unfortunately inherited this genetic mutation, number 1, the risk of developing cancer is much higher. And number 2 is that the risk of developing cancer at the earlier age is also much higher. Then a personal history of polyps. That means that if you have had a previous history of polyp, then the screening modality for colon cancer will be much earlier, because it shows that there may be other polyps growing somewhere else that we need to monitor. And of course, another very important thing is the inflammatory bowel disease. Fortunately, the inflammatory bowel disease are not very common among the Blacks. It's more common in the West. But as I said earlier, because of our westernization of our diet, westernization of our lifestyle, inflammatory disease, bowel disease is really coming up among even the Blacks and the Asians. Next slide. So the other risk factors are the factors that we can change, the factors that are within our purview that we can. Number 1 is being overweight or obesity. So it's very important. We have the ability to control our weight. And of course, we can do that by controlling our diets and increasing our activity. So other things include sedentary lifestyle, not being physically active. For those of us who work in an environment where you sit from morning till night, again, it raises your risk of colon cancer. And because these factors is within your purview, you have the ability to change or to get better. The number 3 is smoking. So under risk factors, the common smoking agent that we take in has a lot of nicotine. And because of the nicotine and a lot of free radicals that are generated, of course, the body needs to do a lot of work to mop them up. And in the process, the cells can go and undergo abnormal growth. Then, of course, excessive alcohol intake is also one of the very important risk factors. Then, of course, eating a lot of processed meat. A lot of studies have shown that processed meat, red meat, have an increased risk of predisposed to increase of developing colon cancer. And one reason they gave is that the red meat takes a lot of time to pass through the colon. So if it takes a diet that takes about 2 hours to pass through the colon and a diet that takes about 5 to 6 hours to pass through the colon, the one that stays longer in the colon gives more exposure, and the more the exposure, of course, the more the risk of developing colon cancer. So red meat has been found, or processed meat has been found, that is still longer in the colon. And because of that, they increase the risk of developing colon cancer. Low fiber diet. One very important factor in our, that is very important to us, is the fiber content of our meal. What the fiber in our meal increases the transit time. Most fibers take about 2 to 3 hours to transit to the colon. So because of that, if a diet or a meal that is higher in fiber reduces your risk of developing colon cancer, while those that have low fiber content stay longer in the colon, and because of that, they increase your risk of developing cancer. Then diabetes and other metabolic syndrome also, they are within a next slide. So why are Asians and Black communities prone to increased risk? I think part of the things I've mentioned, part of them, basically lifestyle factors and healthcare factors. The lifestyle factors I've mentioned: low fiber diet, obesity, less physical inactivity, diabetes mellitus, smoking, and alcoholism. So these factors are very important. If we're able to modify these factors, because they are modifiable factors, if we're able to modify these factors, we realize that it will reduce our risk of developing colon cancer. Of course, the other factor include the healthcare factors, meaning it has also been noticed that the screening, the number of Blacks and Asians that go for screening is very, very low, for maybe cultural reasons and other factors, or of course, disproportionate access to healthcare. So screening is very important. A lot of Blacks, Asians don't have access to screening method, or they don't even respond to screening calls. Then, of course, delay presentation to the hospital because of our culture. Sometimes you have a symptom, you want to take something traditional, rather than present to a physician to assess you and look and check and check the system. Okay, then of course, reduce awareness is very important. These are another reasons why we are taking this webinar, to increase the awareness about colon cancer, very important. Then language and cultural barriers. Then of course, one very, very critical thing is attributing rectal bleeding to hemorrhoid. I've had situations where a patient had rectal bleeding and an inexperienced physician is managing the patient as hemorrhoid, whereas the patient actually presented an early rectal cancer, which if he had met an expert or an experienced physician, he will have been able to quickly screen the patient, do a colonoscopy. And so these are all factors that increases the risk in Blacks and Asians. Next slide. So one good news for us about colon cancer is that it can be prevented. In fact, among all the cancers that we have managed, breast, colon, prostate, colon cancer, I always tell my colleagues, is one of the friendly cancers. No cancer is friendly, but I can tell you that colon cancer is a bit friendly, because you can be screened, you can be picked early, and it can even be cured when appropriate treatment is given. So what do we need to do? Eat a lot of fruits and vegetables, increase fiber in our diets. Another very important thing is we need to increase our physical activity. We need to increase our physical activity. Obesity has to be addressed. Overweight, we need to reduce our weight. So very important. We need to cut down alcohol intake, and we need to completely stop smoking. Sometimes a small dose of alcohol is fine for the body, but excess alcohol is not good for the colon. Then, of course, we need to, take up our invitations for screening. Very important. So, very important. So this is a quick poll for us. Select which one that applies to you. So what are the most common symptoms? Do you know any symptoms of colon cancer? Which one are the most common symptoms of colon cancer? Blood in the stool, change in bowel habits, stomach pain, bloating, unexplained tiredness, none of the above. Any message in the chat box, Alash?
Yes, I think blood in stool, and the other one was a tiredness, but then isn't it that also common for other kind of cancers as well?
Okay, let's move.
Yeah, blood and stool was the main thing, and then some people have selected all four as well.
Yeah. So, so how do we prevent colon cancer generally among the Blacks and Asians community? Again, the prevention addresses the risk factors, okay? So the risk factors, which include the healthy lifestyle. So we need to eat a lot of fruit and vegetable, very important. We need to increase our physical activity. I mentioned that we need to take about 30 to 40 minute exercise about 3 to 4 times in a week, very important. We need to avoid a sedentary lifestyle. You know, if our job entails sitting down morning till night, we need to try and adjust and see how we can improve our physical activity. We need to monitor our weight to ensure that we don't tilt towards obesity. Very important. And we need to stop smoking and, of course, reduce our alcohol intake. Then for screening, very important. The most important thing in preventing colon cancer is screening. So for those of us who live in the UK, there's an NHS screening guideline for us, which is available. So let's try and embrace it. Let's try and accept calls for screening. And if we have any signs, of bleeding pyorectum and all that, let's quickly present our GPs so that they could, assess us and ensure that there's no problem. Then for those of us who have a family that has a colon cancer, particularly first degree relative, that means your brothers, your sisters, we need to know that we need to start screening at a much earlier age. I will still talk about screening later, so it's very important. Then, of course, we also have to encourage our family members to go for screening. Then, of course, we need to we need to try and discuss these symptoms among ourselves. We should avoid stigmatization and fear. Next slide. So what are the symptoms to watch out for in colon cancer? Number one is blood in our stool. Now, the blood in our stool is very important after the age of 40 years. Now, if you're a patient with the age of 20, 25 years, blood in our stool may likely be hemorrhoid. But if you're having blood in your stool for the first time after the age of 40 years, please, you must go for screening. Is a warning sign for colon cancer. Then, of course, changing bowel habit. What do I mean by changing bowel habit? Some people, they go to stool once in a day. Some people go to stool twice in a day. Some goes once in 2 days. That is your routine. By the time that routine changes to something else, for instance, you stool once in a day, and now it becomes once in 2, 3 days. Then, of course, that is changing bowel habit. Or you stool twice in a day, then becomes once in a day or once in 2 days. That is changing. So you need to go and get your, see your GP. Then, of course, abdominal pain. The abdominal pain in colon cancer are usually very dull, aching. They are not really consistent, but very important. The change in stool, change in bowel habit, and blood in our stool. Then weight loss, very important. The unfortunate thing about weight loss is that at the early phase of the cancer, where one can be screened, you hardly get weight loss. By the time weight loss manifests, most likely the cancer has advanced. Then feeling unusually tired is very important. The loss of appetite, very important. Okay, next slide. So how do we diagnose patient with colon cancer? For every patient that has any of the symptoms mentioned earlier, the first thing we do is to interact with a GP or interact with a physician, describing your symptoms to the GP and your physician. And after this explanation has been done, then your physician examine you. There's a general physical examination that is done. You check for pallor, check for jaundice. Then, of course, the abdominal examination and the examination of the of the rectum. Then, of course, the next thing is to do an investigation. The most important investigation for colon cancer is a colonoscopy. And you can see the image on my right is just describing or showing the classical colonoscopy. The colonoscope is just, a tube that is passed through our anus. It goes through the colon, the rectum, and, transverses all the colon. And the goal of this this colonoscopy is to check whether there are cancers in the GIT, the colon, or sometimes whether there are polyps, which we mentioned earlier are the early growth within the colon that may eventually progress into colon cancer. So this is it is the most important investigation for patient who has colon cancer. It's a bit discomforting, but it's tolerable. It's painless. I'm sure the GP will explain further that it needs to be done once patient presents with any of the symptoms mentioned. And the other benefit of the colonoscopy is that once a polyp is seen on colonoscopy, or a tumor is seen, or a tissue can be taken, for laboratory examination, that is for histological examination, which will give us a definitive, diagnosis of colon cancer. Next slide. Yes, you can see these are colonoscopic images on my right hand side. The one on the upper side, yes, that one, the one on the up, on the one is showing a colon cancer. You can see the colon cancer. Alosh, you can put the cursor there. Yes, that's how a colon cancer looks like on a colonoscopy. Okay, and the one below is showing a polyp. That is how a polyp looks like. So the polyp is like a pre-malignant lesion. It's a pre-cancerous lesion. Okay, it's essentially benign. And if you are lucky that colonoscopy picks a polyp, an expert colonoscopist can remove this polyp and completely eliminate your risk of colon cancer. However, if the colonoscopy showed a tumor, I mean something that has gone beyond the polyp stage, then of course the biopsy will be taken, and the histology will give us a definitive diagnosis, and of course treatment will be planned. So essentially, it's done under some mild sedation, and a routine colonoscopy takes about 30 to 45 minutes to complete. Next slide. So why is the benefit of early detection? The benefit of early detection of colon cancer is, number one, when you detect colon cancer early, or when colon cancer presents early, the outcome of the cancer is actually tied to the stage of the cancer. So for those who present early, this 5-year survival, that means the ability to live beyond 5 years is about 90%. It means that for every 100 patients that has an early disease or stage 1 disease, more than 90 of them will live beyond 5 years. And they may even be completely cured of this disease. However, for those who present with stage 3, stage 4 diseases, that means those who present with tumor that are spread to other parts of the body, the outcome, unfortunately, is not very good. The 5-year survival is about 17%, meaning that majority of them will not, live up to 5 years. And one of the reasons for this awareness is that we want to, as much as possible, pick our colon cancer as early as possible, so that a lot of patients can survive beyond 5 years. So you can see that for stage 1, this is about 90%, for stage 2, about 80%, for stage 3, about 50 to 62%, but for stage 4 disease, of course. So early detection makes a lot of difference in colon cancer. Next slide. So now, for those who have been diagnosed, a physician has seen you, you have a history, you have been examined, the colonoscopy has been done, histology taken, and biopsy showed is a colon cancer. What are the treatment options? The number one treatment options is surgical intervention. For me, who is a surgeon, essentially what I do is to go and remove that part of the colon that is affected by the colon cancer. However, the treatment is a multi-modality. That means the surgeon oncologist like myself, the medical oncologist, the radiation oncologist, we come together and discuss this patient and design a treatment modality for each patient. We try to individualize patients. Sometimes we may decide that the surgery will come first before the medical therapy, before the radiation therapy, or sometimes we decide, okay, because of the stage of this cancer, we're going to give radiation therapy first or medical therapy before the surgical intervention. So essentially, the multi-modality treatment involving the surgeon, the medical oncologist that administer the chemotherapy, then the radiation oncologist that administer the radiation therapy, And of course, the nurse oncologist, the pharmacy oncologist, because patient with that are diagnosed with colon cancer undergo a lot of psychological, challenges. So they need a psychologist, and the nurse oncologist to give them psychotherapy to be able to, pass through the initial shock of that diagnosis, and of course how to, then of course one other very important thing we also, try to join them to the colon cancer awareness group, because usually we have a colon cancer awareness group, colon cancer peer group, in our environment, depending on where we live. In my environment here, I have quite a 2 or 3 patients that have treated for colon cancer. And when I have a new patient that develops colon cancer, I say, okay, come and talk to this patient. Let them know that this diagnosis is not the end of life. They can be well treated, they can be cured once they're able to get the proper treatment. Next slide. So again, screening is very important. As I said, the colon cancer is one very important cancer that is friendly, because it can be picked early, and there's also a pre-cancerous stage that once picked, patient can be completely, patient will be stopped from progressing to colon cancer. So very important. The screening is very important. We must get ourselves screened. For the recent screening guidelines is essentially using the fecal immunological testing, which is done annually. Okay, and what it does is that it tests for the presence of blood in the stool. So once it turns positive, then the patient automatically progresses to the next phase of the screening, which is the colonoscopy. So, and the aim of doing the fecal immunological test is that because colonoscopy is an invasive procedure, we try to limit the number of patients that comes for colonoscopy. So we screen patients with the fecal immunological testing test. So maybe you train 100 patients, and maybe if about 5 or 10 that are positive, then they progress to full, length colonoscopy. So we need to, respond to calls for screening. And once the screening results are, are out, then we should abide by the, treatment modality. Okay, next slide. So who are the people that should be screened? Very important. The traditional screening guideline show that anybody above the age of 50 years should be screened. But over the last 2 decades, as I said earlier, the prevalence or the incidence of colon cancer, the age is going down from 50 to 45 to 40. So recently, the screening guideline has been modified in such a way that for high-risk patient, meaning patient who has a first-degree relative who has developed colon cancer, or who has a previous history of polyps, they need to screen much earlier, or those who have genetic predisposition, or those who have inflammatory bowel disease. So once you have any of these symptoms, you may need to get your screening much earlier, around the age of 40 years. But for normal patients who had no family history, no inflammatory bowel disease, no genetic syndrome, screening can start around the age of 45 to 50 years. So that is the recent, screening guideline according to both NHS and most of the societies. Next slide. So a lot of myths about colon cancer, but again, one of the reasons for this presentation is to debunk some of the myths about colon cancer. I don't know whether let's find out. So Alosh, can you maybe next slides?
Yeah.
Let's see. Okay, good. So again, these are some of the myths that about colon cancer. One, colon cancer only affects older people. That used to be in the past. I can tell you now that I've managed patient 18 years diagnosed with rectal cancer. I've managed patient about 23 years diagnosed with rectal cancer. I've managed patient with 30 years diagnosed. So I can tell you that young adults also develop colon cancer. No symptoms means no cancer. Of course, it's not true. Again, because sometimes we do not pay attention to our physics, we may think that we do not have symptoms. So sometimes I ask my patient, do you check your stool when you, after passing stool, do you check your closet? Do you see blood? Do you check your stool? Is it black in color? you know, is the color the same as your usual stool, or it has changed to black, or there's some blood stain? So some patient will tell you that, no, I don't have blood in my stool, but actually, have you checked your stool in the last 1 week? Most patients don't check their stool. So sometimes you'll be surprised that when you check your stool, you may actually that there are actually symptoms, but because just that you are not aware. So early cancer often has no symptoms at all. So that's very important. Then of course, colonoscopy is dangerous. Colonoscopy is very, very safe. Colonoscopy is very, very safe, and it's very important that we should get screened. Next slides. So to round up, what are the key messages? Colon cancer is very common. Please, we must take note of that. But again, creating awareness has found to save a lot of lives. Okay, then early detection also is very important, and early detection means identifying, getting the pre-cancerous lesion, which is the polyp. Okay. Thirdly, a healthy lifestyle lowers your risk. We need to increase the fiber in our diet. I mentioned earlier that the fiber containing meals take 2 to 3 hours to pass through the colon, while low fibers take about 6 to 7 hours to pass through the colon. So it means that the more exposed the colons are to this meal, the more the risk of colon cancer. And of course, screening does a lot of work in minimizing, preventing colon cancer. Never ignore blood in your stool. Next slide. So before we go, colon cancer is largely preventable. Most cases start as polyp. So during colonoscopy, polyps can be removed and the cancer can be, prevented from, progressing to frank cancer. Screening, find it early when it's most treatable. And if you have symptoms, talk to your doctor. Don't wait. Next slide. Thank you, everybody, for your attention.
Thank you so much for that presentation, Dr. Inga. That was wonderful. You've answered so many questions during the presentation itself, but the ALIBSA community would have a lot of questions. I will like Dr. Abalanle to go through the questions now.
Yeah, thank you very much for this insightful presentation. And if you have any question, please go ahead and ask. You could raise your hand or put it in the chat box. While we're doing that, if you could switch on your camera and so that we can take a snapshot of the people that are here today. Thank you very much for joining us.
Yeah, please, if you could do that for 1 second, that would be great. Thank you very much. Thank you.
Yeah, thank you very much. We have Satar Omitogo. Please unmute and ask your question, sir.
You are muted. Unmute.
Can't hear you, sir. We can't hear you, sir. You need to unmute yourself, sir. You click on the...
Would you unmute him from your end?
Yes, sir. No. I can't do that. I don't have...
Yeah, he has to do it himself.
Yeah.
If it's easier, you could put that in the comment box as well.
Yes. And then we could quickly go to Sharifa Aduni. I'm trying to click on that.
Yes, Sharifat Amin. Yes.
Yeah. Please.
Okay. Yes. Thank you for the presentation. So useful. What I want to know, because to know the symptom, can you hear me?
Yes,
Yes.
ma'am.
Okay. Okay, because somebody is disturbing there. Because of our method of the toilet now, what do you call it? We in the sink, right? Now, how will one know that one has got blood in the stool? Because this will be flushed away, and unlike back home, we just defecate in a potty, then you can see what is there. But in this case now, no potty, and I can't see how one can know it when there is no serious symptom like stomach ache or whatever. So how do we know this, that something like that is happening to us?
Instead, try Calgon 4-in-1 gel. Compared to vinegar, when you add Calgon
Okay.
to dirty water, it prevents more of the dirt buildup in the washing machine. Just
Someone is very
for a front
loud here.
washing machine.
You can okay, mute yourself, ma. Okay, can we? Would you want to respond to that while we take the next
thank
question?
you, Sharifat. Yes, in fact, the water closet is one of the best ways to identify blood in the stool, because once the stool drops on it, the water turns red, and the closet turns red. So it's actually far easier compared to the traditional, the ones you have at home where you go, the toilet, the stool goes into the pit, you don't know what is there. So once the blood drops on the water closet, everything turns red. So it's actually far easier to identify, stool in the feces. But I think more importantly is the change in bowel habit. We must know our bowel pattern. If you pass through once in a day, that's your routine. By the time it changes to once in 2 days, once in 3 days, you need to be screened. You pass through twice a day, it changes to once in 3 days or 3 or 4 times in a day, you need to get screened, particularly when you are up to your 50 years.
Thank you very much. Thank you.
Thank you. Then we could have John Alei, please. Could you please ask a question?
All right, thank you very much, Dr. Lukman, for the detailed explanation and description of everything. I appreciate the presentation. So my question is this: when it comes to exercises, are there specific exercises that are targeted at improving or helping to prevent colon cancer? I ask this question because I do the kind of work I do involves lots of movement for me, and I know a lot of persons might be in that same kind of category. So, does that cover for it, or do we necessarily have to do a specific kind of exercise? I understand. I know you understand what I'm trying to say. So, if there is a specific kind of exercise, maybe you let us know, or the basic is just to avoid a sedentary lifestyle and ensure we have a lot of movement going on. Is it even if it's about movement? Is it what kind of movement? Is it upper body, lower limbs? I just want to know if there is any specific kind of exercise that is targeted at improving one's health or preventing the risk of having colon cancer. I appreciate if you could give more insight on that. Thank you.
Yeah, thank you. Please go ahead, Dr.
So thank you very much, Mr. John, my very good friend. Yes, there are no specific exercise that is required. The more important thing is to avoid a sedentary lifestyle. Now, let me use myself as an example. For me, I do not need any exercise, because by the time I do a ward run for about 3 to 4 hours, I must have taken so many steps. Sometimes I stand operating for about 3 to 4 hours, moving my legs left and right, do my ward run, teach residents doing the ward run, teach medical students about 3, 4, 5 hours. So I'm sure that those alone, by the time I move from one ward to the other, I must have taken more than 10,000 steps in a day, which it takes, keeps me fit and, predisposes me to sedentary lifestyle and the risk of colon cancer. So no specific exercise, essentially, is to prevent a sedentary lifestyle.
Thank you very much for that. Mr. Satar, do you want to ask your question now, sir?
I'm just listening.
Okay.
That's okay. I don't have any question to ask. I'm just
Okay.
observing and listening. That's all.
Okay. Could you please lower your hand, or I could do that from here so that I'm showing it. And then the question in the chat box, I'll quickly take that before. Does ulcer graduate into colon cancer, and what is or are the cause or causes of colon cancer? Is it diet, sugar, stress, or a combination of different things?
Okay. Ulcers are completely different entire problems on their own. They do not progress to colon cancer because all already found in the stomach, whereas the colon cancers are found in the colon, which is the large intestine. Okay, so it's very important that we should be able to differentiate between the two. Then the reality is that the causes of cancers are unknown. That is the reality. However, we have tried to look at what are the risk factors which has been highlighted in the presentation. But to say this is the specific, because it's not sugar, it's not this, it's not that. The most important thing about the colon and colon cancer is the duration of exposure of your meal to the colon. So, and that is determined by the number of fiber in your meal. The more the food stays in your colon, the more the exposure to the carcinogens, that means the cancer-containing agents, and the more your risk of developing colon cancer. So the quicker the food passes through your colon, the more the fiber in your meal, the quicker the food passes through your colon, and the less your risk of developing colon cancer. So I think that should have responded to your questions.
Thank you very much. Just transit time, maybe. Mr. Bello Buba, do we have you? You can ask a question, please. Mr. Bello Buba. You have your hand raised. Okay, we could go to Mr. Abraham Aturashi.
Hello.
Okay,
Am I
please
audible?
go ahead. Yeah, we can hear you now.
Thank you very much, Dr. Lukman, for the insightful presentation. I have two questions to have clarification. Number one is regarding those that have the risk factor for developing colonic cancer. How often are they expected to be doing the colonoscopy? Is it annually? Is it after 6 months? Is it 3 monthly? Or there is a specific period in which they are expected to be doing the screening in order to have it early or to prevent, as the case may be? Secondly, you also talked about the issue of having a colonic polyp, that those with colonic polyp after colonoscopy, that if it is excised, if it is removed completely, the risk has been eliminated. Does that mean those patients that had the colonic polyp, after removal, you don't have to follow the patient up for colonic screening with colonoscopy, or there will be need for that? Thank you very much.
Okay. Thank you very much, Dr. Bello. So with regards to the colonoscopy, as I said, most of the guidelines are gradually adjusting from the age of 50 to 40, but traditionally screening starts from 50 years. So if the fecal ocular blood is negative, no progress to colonoscopy. If it turns positive, you progress to colonoscopy. Now, when you have your colonoscopy and it's fine, no problem. You will need another colonoscopy in 5 to 10 years. And why it was designed 5 to 10 years? Because an average polyp takes about 3 to 5 years to progress to full-blown cancer. Okay. However, if you had the patient had a colonoscopy and the polyp was found, so the colonoscopy, what we do is that we do a polypectomy, we remove the polyp. Okay. Now that lowers the frequency of the screening because the patient has now shifted from a low risk to a high risk. So presence of the polyp in a colonoscopy, it changes the patient from a low risk to a high risk. So once the polyp is detected, it means the patient will now continue with annual colonoscopy for 3 to 5 years. If after 5 years, no fresh polyp, they will progress to 3 to 5 years. Annually for 5 years. Then after 5 years, no polyp, then every 3 to 5 years. Then by the time it's done, after another 10 years, they will proceed back to 10 years. So that is how we follow up patient with polyp. So you do a colonoscopy, no polyp, your next colonoscopy is 5 to 10 years. You do a colonoscopy, you found a polyp, lipectomy is done, annual colonoscopy for the next 5 years, then subsequently the next 3 to 5 years.
Yeah.
I
Thank
hope
you for that. Okay. Mr. Abraham, sorry, Atsorashi. Please go ahead, sir.
Yeah, thank you. May I say, Brother Layinka, I'm greatly appreciative of your presentations. Not just what you are working, but actually the material in this presentation. How you are putting together things that matters, that actually either remind or educate most of us on this platform. May I just add that, yes, there's difference, if you allow me to say, there's difference between that in UK and that in Nigeria or other parts of the world, Africa in particular. Like here, people are invited. For initially, they are given their feces test, and some people I've seen, I'm in the community, some people ignores it, but unfortunately, they found out it's too late. Sadly, while you were on, I was looking at the screen and people were saying, do not be afraid to go for your test. That is a very, very crucial point. The earlier you go, the better for you. Damn it, whatever is going to be the discovery, but that will help you to progress. It's better for us to know where we are than remaining linger and thinking, oh, it's not me. Me. Oh, I'm this and that. And most of us don't even know. We don't have the history of our parents. Most of us who were born over there. So therefore, I'm totally in line with what you are saying. The earlier you go for your test, the better. We've seen people that are invited, they do not go for their feces to be tested, and they turn out to be stage 4 when discovered. And yet, this is in the history of the family. Even the daughter who's at the university level don't even believe there's a cancer. That was so stunning. So there's a lot we need to do more in this community in particular. And I know there's less difference between our community and community of others of our race. So I'm employing people to do take home what you have said today. Go for your test. Here, when you are invited at a certain age, if you go, fine. If you don't go, they will do it again. But if you don't go, they are not going to force you at all. Therefore, the onus is on us as individuals to attend for this. It is better for us to do that test than to ignore it before it is too late. Thank you.
Thank you, sir. I think that's more like an advice from you. Thank you for that, sir. And we have in the chat box people thanking you for the presentation, and then okay, is there a data on? Could you please mute yourself, Mr. Gerard? Is there a data on colon cancer burden in Nigeria by region or ethnicity? Are we experiencing a true rise or better detection? So that's a question for you, sir.
Very good. With regards to data from Nigeria, because we don't have a screening program, we do not have a national data about the prevalence or incidence. But the hospital-based data that we have has shown that most of the cancers that present to our hospitals, particularly gastrointestinal cancers, colon cancer is the highest, has the highest number in terms of GI cancers that present to us in the hospital, okay, in Nigeria, both from the southern Nigeria or the northern Nigeria, it doesn't matter, okay? And essentially, there's no really ethnic preponderance or prevalence in Nigeria. What we have is that the incidence too is gradually coming up, and again, it is still attributed to westernization of our diet. You know, I'm supposed to take, for instance, beans and yam. Maybe when I was growing up, I took beans and yam. Now I take shawarma, I take indomie in the morning, I take spaghetti in the afternoon, and I take bread and egg in the evening. No single fiber in a day. In a day, no single fiber. So compared to when we were growing up, where we take rice and beans, beans and yam, beans and bread, these are things we eat when we are growing up. And this food contains a lot of fiber. We take pap and akara. These are foods that contain a lot of fibers that when you take them within 2-3 hours, they transit the colon and they come out. But now you take indomie in the morning, you take spaghetti in the afternoon, you take bread and tea, and no single fiber in a 24-hour diet. So I think those are the factors that are likely to increase our, the risk of colon cancer in our environment here in Nigeria.
Thank you very much. As much as we are enjoying the program, we are running over time. We just have 15 minutes extra just before then. Thank you very much. This is from someone. Thank you very much for the presentation. Talking about having a high fiber diet. What if someone can't hold down fiber, as in any slightest fiber in the diet, send this patient on a diarrhea sentence for days?
It's not a very common thing. Most patients tolerate fibers. Sometimes what patient may not tolerate may not be fiber, may be something like gluten, maybe being tagged as fiber. However, if you find yourself in such a situation, what you need to do is to contact your dietitian so that they can find a way to find a graded fiber that is tolerable to your GIT. But essentially, most patients or most people can tolerate fiber. What people cannot tolerate most of the time is gluten that you find in wheat and some other processed meal. But as I said, if at all you find yourself in such a very precautious situation, just discuss with dietitian so that they will find a tolerable dose and ratio for your colon. I think that's the way forward.
Yeah, thank you very much for that. I think someone asked about data. This is coming from Mr. John Halei. I think someone asked about data in Nigeria with respect to prevalence and risk factors.
I think I've responded to that. Yeah, I told you we don't have screening data, but what we have is hospital-based data.
Okay. Would there be any pointer to where they could go to if they really want to do the screening on their own? Probably like private, or there are some hospitals that you could recommend in Nigeria. And because of your background that you've worked or you've done something in the Asian country as well, is there any place that you could, anything that you could give them advice on for them to go to those places for screening and then probably for management of colon cancer? Thank you.
Yeah, thank you very much. So, number one, if you are above the age of 50 years, you should have gotten your first screening. So, what you need to do is to visit any hospital around you that offer, GP services. And I think those are the ones that will now request for colonoscopy. And luckily, in most of our major cities in Nigeria, we have colonoscopy services in most of our cities in Nigeria. I'm not aware of any, maybe only maybe 1 or 2 centers in the north, but the majority of the centers in the southern part of the country has colonoscopy services in the capital city. So by the time you are 50 years, you must get your first screening of colonoscopy. So go to the hospital, tell the doctor, I want to screen for colon cancer. They will write a colonoscopy for you. You go to endoscopist, they scope you, and you have that as a baseline for subsequent, colonoscopy. We do not, in Nigeria, we don't have much of the fecal immunological testing here. The one we have is the traditional fecal cord blood, which is slightly less sensitive compared to it, but we still have colonoscopic services available that patient can take advantage of in Nigeria.
Yeah, you can still go to some labs like Macure, First Clinics and all that. So it's a place that someone could go to if they're in Nigeria. So the other part of the question was about from Mr. Gerard, are we experiencing a true rise or better detection?
I can tell you that it's probably both. And why I said it's probably both is because 10 years ago, how many colonoscopy machines do we have in the country? I can tell you 10 years ago and now, the colonoscopy machines may have doubled or even tripled. So it means that If you can scope 100 people 10 years ago, now I can scope 300 people. So that means the chances that we are detecting more is higher. Then the same thing, 10, 15 years ago, we take more of fiber-containing diets. Now, 10 years down the line, we take more of shawarma, we take more of Indomies and all that. So we could also be experiencing a true rise. But I think that a true data will be able to, will be able to prove us right.
Thank you very much for that. Do we still have any questions? Okay, please go ahead, sir.
Okay. Thank you again. One, I will encourage people not to wait, particularly those who are here. Do not wait for your doctor to ask you to come. Once you notice all that has been said is within the agreement with the GP, you can go to your GP or you check out on the internet the stomach cancer research. You will get what you need to do, the number to call. At certain age, you are allowed to, even if you are not invited, if you have been invited for about 2 times, they give space in between. And the 3rd time, maybe your age is going 70. If you feel all this, they still ask us to, look, give us a call, we will do the test for you. It is very important because they will say, oh, you do not have any trace by now, but that doesn't mean you will never have it as you go ahead, according to research. Also, please, Dr. Olayinka, could you tell us, your audience, the difference between the stomach cancer and colonoscopic cancer? Because we know they are both in there. So maybe that will also interest people and give us more knowledge in that area. And everyone, you can also go and do your research. And remember to do the research on your family history. You will find out a lot of things, and that will put you on the toes so that you can quickly make those steps that you need to make. For example, if I don't know my family has got diabetics in my family, I say, oh, doesn't matter. But if I knew this, I will make a quick check. Not only make a quick check, I will also stay away from those things that we know that causes cancer. Please, I'm sorry if I'm speaking too much. Dr. Olayinka, sorry for permitting me. Thank you.
Thank you, sir.
So thank you very much, sir. The stomach, as I said, is quite different from the colon. Now, when we take a bolus of meal, it goes through our mouth, then to the esophagus, where we call the food pipe, and it lands on the stomach. Okay, and at that stomach, that is where we commonly have what we call the ulcer. Oh, I have peptic ulcer, I have GI ulcer. That is where we commonly have ulcers. That ulcer may also progress into stomach cancer, or even a fresh cancer can develop from that stomach. However, when the food lands in the stomach, the food is churned round, mixed with enzymes, then it gradually, gradually goes into the small intestine, which is about 6 meters long, then before ending up in the colon. Okay, so the colon again is a completely, different part of the GIT. So the colon cancer is completely different than the stomach cancer is completely different. So that is the way the food navigates, within if we take a bolus of meal. So it lands in the stomach, so cancer can develop there, the small intestine, then to the large intestine, which is the colon. So there are 2 different cancers entirely.
Thank you very much. Yeah, we have a question. Someone is thanking you as well. And then, what of the risk of colonoscopy? I know someone that lost her life due to a colonoscopy. And we have someone here who is saying that there is Union Diagnostic Lab that does a colonoscopy. That is an OAUTHC Ile-Ife. So that's just a pointer to where you could go to. So please, you could answer the question.
Okay, so as I said, for colonoscopy, most centers in Nigeria have colonoscopy. Most tertiary hospitals have colonoscopy. In this hospital, we have about 2 to 3 colonoscopy, tubes. In Ife, in Ife, Ibadan, Oshogbo, almost every of those hospitals have their. At least I'm aware because I have worked in those areas. I have colleagues there. So again, even in northern Nigeria where I live, we have in my hospital here we have a lot of colonoscopy. In this state, we have more than 15, 20 colonoscopy centers. So I think that's not a problem. I think the other question I forgot.
Yeah, it's about what's of the risk of colonoscopy.
Very good. So unfortunately, sorry for the person that died during colonoscopy, but I can assure you that the death is not attributed to the colonoscopy procedure. Perhaps that patient have an underlying medical condition that increases the risk of death following exposure to some mild sedation. But the procedure itself, I can assure you that it's not mortal in itself. So sometimes somebody has an hypertension which is not properly taken care of, is not on medication, is not regular medication, is not a follow-up. And of course, you just put him on mild sedation and the heart suddenly stops. Oh, he died while doing colonoscopy. Or somebody is a diabetic patient, uncontrolled, not regular medication and all that, and mild sedation. But ordinarily, the colonoscopy itself is very, very safe. Very, very safe. So that is why before a patient goes for colonoscopy, we need to take a thorough history and examination and look at, does this patient have a comorbidity? So if this patient has a comorbidity that is not well managed, we need to, first of all, manage the comorbidity, ensure that the patient is more stable. Then we may need to review the sedative agent and say, okay, which one is compatible with this patient, which one is not compatible with this patient. Sometimes we may even need to do a complete intubation to be sure that we do not want to, sedate and patient from there, gives up. So that is why thorough history and examination. You don't just go to a lab and say, I want to do colonoscopy. No, it doesn't work like that. Because if you have a comorbidity and somebody just puts you under the colonoscope and it gives you, I say, oh, colonoscopy is unsafe. No, you need to see a physician that will take a history, examine, sure there's no comorbidity, there's no hypertension, diabetes, or any other thing that can increase your chances of death from the procedure. So I think that is it.
Thank you very much for all the wonderful things that you've said today. But I have one more. I think we could just take this one. Then after this question, if you have more questions, please send it to the community so that Dr. Olainka can have a way of helping us out on that. But being a procedure, there must be some complications associated with the procedure, not the anesthetic complication.
Yes, you are right. The two common complications associated with colonoscopy are one, perforation of the colon. We can make hole on the colon. I mean, it's making hole on the colon, okay? The number two is hemorrhage. But I can tell you that the incidence of the prevalence of these complications are less than 1%, because most of the time you are doing a diagnostic colonoscopy, not an interventional colonoscopy. Most of these complications are actually higher during interventional. That means when polyps are being removed, or maybe somebody is bleeding, you are putting a clip for the patient. But if it is just a normal diagnostic colonoscopy to detect colon cancer, I can assure you that the complications are extremely rare. They are extremely low. And if it happens, most majority can still be managed by conservative management. So even when there's inadvertent perforation, I can tell you that most of them can be managed conservatively without needing any intervention. So I think that is it.
Yeah, thank you for that. Is the cost affordable in Nigeria? Like how much?
Yes, the cost across the region, most of the and across whether it's government or private, most of the government hospitals, colonoscopy is less than about 80,000. Most centers are less than 80,000, 60,000, 40,000, 50,000 never. These values are less than maybe 20, 30 years. Northern Nigeria is even far cheaper. It's even far cheaper in northern Nigeria. Here where I work here, we scope around 40,000 or so. Plus the clean the bowel cleanser. So everything about 50. So in the private sector, it may even double or triple. But I can tell you that majority, it's affordable. The problem we have with our patients is that they don't prioritize their health care. affordability is not majority of the problem we face. I tell patients, you say a patient makes 10,000 naira per day, and for a month, he makes about 300,000 naira. And you tell him that insurance cover for your health in a year is 150,000. In a year is 150,000, or maybe 80,000, for instance. Tell him to go and do insurance. You can't do that insurance. And that insurance will have covered for a colonoscopy.
Thank you.
Cost is not really the problem, but prioritizing of our healthcare, I think, is a very key factor here.
Thank you very much. And we have some notes in the chat box. Someone says, Ayola is saying 40 to 80,000 naira based on the education. And then thank you for the kind words, Ms. Mobola Uyeleka. Thank you very much. So if you have any questions, we have our links here for you to join us on various platforms, and you could send your question in, and we still have Dr. Olayinka to answer. Thank you very much, everyone. Okay, Alosh. We can't hear you, Alosh.
Thank you very much, everyone, for joining. I know we don't have much time, so I'll just quickly mention a couple things, and then we will finish the webinar. But yeah, thank you so much for everyone for joining in and asking all the good questions. Like I mentioned, we always have a pretty keen bunch asking questions, which is wonderful. So if you have got 2 minutes, could you please give us some feedback about today's webinar, but also about ALIBSA in general? So this would really help us to understand what ALIBSA needs. So if you do have a phone that can scan a QR code while you're watching the webinar, please do that. Otherwise, we will also put this link in the chat and also in the WhatsApp group later as well. So give 10 seconds for that. Yeah, we'll put that in the WhatsApp, in the chat and the WhatsApp group later on as well. So I've mentioned at the start of the ALIBSA, obviously we support that participatory research. So this is an example of that, the Manager Health Initiative. So the idea is to increase cancer awareness in the Somali community. So this is a project that is funded by the NHS, and ALIBSA is supporting that mission. So this is one of the examples of ALIBSA's wider missions and how we contribute to health equity across our global majority communities. We have another very interesting and important topic to discuss next month. So the next webinar will be on the 24th of August, again, another Monday. And the key topic for us would be perimenopause, the hidden transition. And we'd have Dr. Halima Samanu, who's an associate consultant OBGYN, joining us for the webinar. So we really hope that we could see all of you for the next webinar as well, and then support ALIBSA as you always do, but also take the learnings from ALIBSA as you go on as well. So this is our next webinar at the same time, 7 p.m. Very summertime, on the 24th of August, which is a Monday. So thank you very much for joining the webinar today, and it was wonderful, and it was really helpful for us to have such an amazing presenter. Thank you so much, Dr. Olayinka, for your wonderful presentation and your patience in answering all the questions. I think that has really made a difference. But if you did have any other question and didn't have the time to ask, please put that in the ALIBSA chat, ALIBSA WhatsApp group, and then we will endeavor to ask those questions to Dr. Olayinka and hopefully get those answered as well. And thank you everyone within the ALIBSA team for making this happen as always. Yeah, most importantly, thank you everyone for joining us, and then we hope to see you next month. Thank you. I'll play a video of ALIBSA just to for anyone who hasn't seen ALIBSA, but thank you so much. Thank you everyone.
My name is Fatiha Nei Odumosu, and I'm an associate professor of physical activity and health promotion in UWI Bristol. I founded ALIBSA, and I'm the lead on ALIBSA. So ALIBSA is an acronym from Aging Lifestyle in Blacks and Asians. It's a knowledge exchange program which is focused on improving health literacy among the ethnic minority background. So the focus is on the Black and Asian communities because that's where I'm from, and that's where the majority of the admin members are from. And we're quite passionate about reducing health inequalities based on the existing health disparities that occur within this group of people.
I'm Chang Ma. I'm a senior lecturer in public health at UWI Bristol. So my role within this ALIBSA network is acting as an admin member and also a collaborator for the ALIBSA network, and also helping to promote this network to the Chinese ethnic minority, and also helping them to have a better understanding about the importance of physical activity and nutrition. Through this network, we can spread this physical activity message to the community.
Yeah, the brain behind ALIBSA is made up of 6 admin members, which include my own self, Alosh Jos, who is the CEO of Cricket Cube, a community-driven cricket business company based in Newcastle. We also have 2 medical doctors on the team, Dr. Giselle and Dr. Abolanle Adisupe, as well as a doctoral researcher, Oluwatobi Fatola. We have Dr. Cheng Ma, who is also a senior lecturer in public health as well. ALIBSA provides a platform whereby community members from the Black and Asian ethnic groups could be empowered through health literacy. And we feel that this would reduce health inequalities among this group of people, thereby increasing access to health services. We believe that when people are literate about their health condition, they have autonomy over their health, they are quite empowered over their health, and they have self-confidence to access health services, and that will go a long way in reducing health disparities among these communities. We will understand the barriers they face in accessing health services, and we can collectively work together to look at a well-tailored form of interventions that would enable them to access these health services. So ALIBSA is a program that helps to empower the communities. We run our monthly webinars, which involves inviting multidisciplinary group of speakers that give tailored health-related topics. And we use this platform to engage the communities on the experience with related topics. Outside the webinar, we have a robust WhatsApp community which has over 120 members, and we do engage with our community members when it comes to resourcing health services, sharing links on ongoing research, sharing links on how to access specific facilities or resources tailored on health promotion within these ethnic groups. We also have a lot of volunteers who join us. Our webinars are well attended from different countries. This is not limited to the UK. We have people join us from other countries such as Netherlands, Canada, Malaysia, Australia, United States, Nigeria, Ghana, and several other countries. We have volunteers that also act as champions that help move ALIBSA within their home country. We do have a platform as well, which is linked with the championship and the volunteering platform, whereby we seek this platform to also mentor early career researchers who are really passionate about lifestyle-related conditions and community empowerment. Our vision for ALIBSA is to ensure that ALIBSA is global. We want to ensure that every country has an ALIBSA champion, and there will be community-driven led health literacy initiatives that would help empower people within the communities. Feel free to join our network. We will strive together to empower the Black and Asian communities. We will ensure we're able to reduce health inequalities within this network.
Thank you everyone for joining us. See you next month.